Good afternoon, everyone. Thank you, Dr. Mujib, for having me here at the Knee Symposium of Sicot conference in Belgrade. My brief is to talk about how to choose the right constraint during knee arthroplasty. I am Vaibhav Bagaria and I work at the Sir H. N. Reliance Foundation Hospital in Mumbai, India. Let's begin by looking at this X ray. She's a 65-year-old female, 2 year post her index surgery. A rotating platform was used. She never felt alright on the left side. There's no history of pain, fever, or any other symptoms suggestive of infection. She complains of giving away sensation when she is walking. These are her varus and valgus stress views and a scanogram. Now, before I proceed to the talk, I would want you to think about what are the possible treatment options for her. It may differ from person to person, and we'll talk about it at the end of my presentation on what I did and why I did what I did. So, when you talk about choosing the constraint, it is clearly a choice between stability and function slash longevity. We want to use the least amount as possible. However, it should be adequate, and that is why it should be the maximum amount as required. It should provide enough stability without compromising the function or longevity. Biomechanically, what happens when we use the constraint design? The constraint is primarily meant as a substitute for soft tissue which is torn or not functional. It increases the capability to transmit load to its fixation to the bone. Therefore, while it replaces the soft tissue and acts as restraint, it also increases the stress across the bone implant surface, and this affects the longevity of the implant. If we look at the choices that we have, the entire spectrum starts from cruciate retaining, which could be high flex, a plain CR, a deep dish, or anterior stabilize. We move on to the next higher constraint, which is a posterior stabilize, followed by Varus-valgus restraint, and finally we have what we call as hinge, in which the femur and tibia is connected and is not having that much degree of freedom. So this is the entire continuum of the constraint from CR to a rotating hinge, and you'll see with increasing constraint there is an addition of cam which get progressively thicker and broader, increasing the size of the box. Now the decision on how or which constraint to use is primarily based on the soft tissue status, but it is also sometimes determined by the bone defect. The cruciate retaining is the simplest one, it is the least constraint. However, it needs a perfect flexion extension gap, preservation of the joint line, intact and functional PCL. The advantage is that it is bone preserving and allows good PCL function and proprioception. The second commonest constraint that is used even in primary situation is a posterior stabilized implant. It offers stability against the posterior subluxation of the tibia and the knee flexion. However, it does not provide any protection against the mediolateral instability. If the flexion and extension gap are not balanced, there is tendency of dislocation of the post and the cam mechanism. So if the flexion gap is large, for example in a revision scenario, if you put a thicker insert, it will appear that the flexion gap is stable, but it would lead to a flexion deformity because of the extension gap being constricted. It can also lead to a raised joint line if the distal femur is cut further to compensate for the large flexion space. So we have to be very mindful of balancing in both flexion and extension. Our goal should be equal gaps and without any elevation of joint line. The Varus-valgus constraint is used in situations of deficient collateral ligament, and there is an inherent, it's meant to replace the inherent or intrinsic Varus-valgus instability or the flexion gap laxity that is large enough and cannot be addressed by a simple posterior stabilized implant. They have a deeper and larger intercondylar box and a correspondingly taller and broader polyethylene post, which may sometimes be reinforced with metal peg for additional strength. We must remember that they do not protect against hyperextension force because they rely on intact posterior soft tissues. So, in the cases where there is hyperextension, the varus-valgus constraint is unlikely to be of benefit. So, you can see from this picture that there is clearly a larger and a broader box. The varus-valgus constraint will only suffice when the flexion extension mismatch is less than 10 millimeter. The joint line is restored within 10 millimeter of the physiological joint line. The femur is reconstructible in the anteroposterior dimension, and that there is at least some functionality remaining in the collateral ligament. If all of these criteria are not met, then we should move on to a hinged implant. A few technical tips: when we do a VVC, we should preferably use a stem with these implants. Have a low threshold of using the sleeves and cone in case there is metaphyseal bone loss. They are rotationally more constrained than a rotating hinge, and the forces transmitted are very high. Hence, the need for the stem to bypass or transmit some of the force down below. A hinged knee prosthesis was originally used in 1950s. It's a metal-metal articulation with movement along a single axis of flexion and extension with a hyperextension stop. However, the results were poor, and the failures were associated with poor implant design, higher constraint, leading to stress transmission across the bone cement interface, and therefore subsequent loosening happened. These articulations also produced metal debris which were linked to early failure. In today's time, it has got very limited use, and it is limited to tumors, extension deficiency, and neurological condition. Today, what we use is a rotating hinge knee prosthesis. It is developed to overcome the flaws of the hinge prosthesis by permitting rotational freedom. This helps in redistributing the forces that pass through the bone implant interface, and also it helps in better patellar tracking, an aspect which is often overlooked when we are looking in the revisions situation. So we use the RHK or the rotating hinge in cases of instability which is not balanced by correcting the implant placement, or that cannot be managed by a lesser constrained PS or VVC type of implant. When there is severe bone loss where the bony attachment of the ligament is compromised, of course they have to be used in the tumors where the resection is distal or proximal to the ligamentous attachment, and sometimes we use even in periprosthetic fracture with loose implant. You'll remember I talked about constraint with the bone defect, and there's clear recommendation that for all type 1 defects, PS implant should be used. For type 2, VVC implant should be preferred, and for anything more significant, we should use an RHK. Finally, going back to our case, you'll see that this is the amount of instability, clearly posterolateral opening that is happening. So for this case, when we opened on table, you can see that there is clear spin-off of rotating poly. It's coming out and disengaging from the cam post mechanism. Is clearly not functional here. So what we did was a combination technique. We reconstructed a PLC by the traditional method, in which we passed the semi-T graft through a tunnel in the fibula and fixed it with a screw proximally at the anatomical point. We also changed the poly to a thicker poly, and this is how you can see that it looks like now. You can clearly see on the femoral side there is a track for the screw, which is the bio screw used for reconstructive PLC. So thus sometimes we have to look into what can be done, and it's a 1-year follow-up. The patient is not complaining of any stability, walking fine. So instead of doing a full-fledged revision, we change the poly to a higher size, adding to the stability, and also reconstructed the posterolateral corner, which was, in my opinion, the primary cause of the instability. But as I said, different people may have different thought process. Someone who chose to do a proper revision with a hinged or a better constrained implant would not be wrong either. To conclude, one should use the least constraint possible, build the bone defect with graft, wedges, sleeves, or cone, assess both the flexion and extension gap to choose the right constraint. When the osseous attachment of the ligament is thought to be compromised, an RHK implant is preferred. Similarly, in cases of hyperextension too, an RHK is preferred. In comminuted periprosthetic fracture with possibly loose implant, the distal femoral replacement with hinge should be considered. One should have low threshold for using stem with increased constraint. There's a complex algorithm for this, and anyone can read it. But in my opinion, the idea is to have minimal constraint and maximum balance. So this is the final outcome of our patient. You can see that we are holding that PLC in the appropriate tension, and you will see that despite the rotational and anterior rot S, there is a good amount of stability. I thank everyone for their attention and welcome any questions they may have on the topic. Thank you.